Okay, perfect. Welcome everyone, and thank you for joining us today. Before we begin, please note that this webinar will be live streamed to our YouTube as well as recorded. So at the end of this presentation, there will be the opportunity to ask questions, and you may either unmute yourself and ask Anil and Caitlin, or you can put the questions into the chat. Enjoy the webinar, and I will pass it over to Kimberly O'Connell, our OCAO Executive Director out of Ottawa.
Thanks, Kate. We're so happy to bring you today's webinar in partnership with this research project and Dr. Anil Adisesh, building on the ECHO OEM project, and shout out to our partners at the Institute for Work and Health. I was going to throw that project into the chat as well. And both of these important projects are making inroads to address the evident gaps that, we see on our work. We have been with the Occupational Illness Prevention Steering Committee, or previously the Occupational Disease Action Plan that Dr. Adisesh was involved in, that I sit at, and the Occupational Illness Leadership Table at the ministry level throughout the system partnerships. So, and really that are looking at discussing occupation in general at your primary clinician. Knowing not all physicians take an occupational history, but some do, talking about the barriers that to taking occupational histories, and helping understand how primary care providers in practice with disease specifically how they can take an occupational history. So without further ado, I'll pass you on to the experts here in the research project with Dr. Anil Adisesh, who is an associate professor in the Department of Medicine at Dalhousie University. He's lead investigator for this study and work in health in primary care in Ontario, improving the recognition and recording of work-relatedness together with Dr. Andrea Furlan. He is the co-lead of the ECHO OEM telemonitoring program for primary health providers in Ontario, and both of these projects are funded by the WSIB. He's trained as a specialist physician in occupational medicine in the UK and is also qualified in family medicine. He worked as Deputy Chief Medical Officer in the UK Health and Safety Executive National Laboratory, and was appointed the inaugural J.D. Irving Limited Research Chair in Occupational Medicine at Dalhousie University in 2013, and in 2019, Division Director in Occupational Medicine at the Department of Medicine at the U of T. In 2022, he transferred back to New Brunswick to work with Canadian Health Solutions as Chief Medical Officer, trying to make inroads wherever he goes. So welcome, Dr. Adisesh. Over to you.
Well, thank you so much, Kimberly, and to OCAO for hosting this webinar. And OCAO are partners with us in this project. And this study we've been talking about is work and health in primary care in Ontario. And it's about improving the recognition and recording of work relatedness. And that doesn't only mean that conditions caused by work, but the effect of work on other conditions as well. So it applies to all patients really of working age, and even those that have retired, because obviously conditions at work may have impacted somebody and only become apparent post-retirement. So just to say a bit more about our project partners, OCAO is project partners with us, and Praxus Health as well, really important in the project management side of things and delivering on the project, and myself at Dalhousie University. And we're funded by WSIB Ontario. We're really grateful to them for funding. And just to acknowledge the rest of the research team there, in particular, my other research colleagues, Dr. Andrea Furlan at University of Toronto and the Institute of Work and Health, Dr. Aaron Thompson, who's also at University of Toronto and with WSIB, and Dr. Christopher Baker at the University of New Brunswick, who's a research collaborator with me on, particularly, he's a computer scientist. So the project I'm going to talk about, it's received ethical approval by the Dalhousie University Human Research Ethics Board, and there's the reference there. And now just to talk a bit about the background to the project, what we're looking to do. So work is a social determinant of health, and I think we all recognize that. And, there's a number of other social determinants of health, and often people say, well, the most important social determinant of health is education. And certainly there's an argument for education, but I'd ask you, what do a lot of people do with their education? It's one of the things that helps you get into employment. And employment's important because for most people, that's where their income's coming from. So, you know, work is important because it gives meaning to people as well. Socialization, you meet people at work, friends, etc. And good work is generally good for people, is what we would say. Corollary to that is being out of work is not good for you. And also, sometimes work can cause problems for people in terms of health, such as chronic disease, injury, sometimes infectious disease, and we saw that with the SARS-CoV-2 pandemic. And you know, people in different occupations had different experiences during that pandemic. It can cause impairment, leading to disability, reduced workability, and sometimes mortality too. Now, as far as primary care goes, most often the interaction that primary care providers have with work is when a patient may come to them asking about an injury most commonly, but it's also important to remember illnesses, but in particular because patients may not realize that the illness or symptoms they have may relate to work, and that's where an informed primary care provider can actually make the link. So there's important links there about work-related illness or injury, but there's also an issue about helping people stay in work or return to work with any medical condition they may have, whether it's, you know, a heart condition, diabetes, seizure condition, etc., that's not caused by work, but it may affect somebody's ability to work and they may need support. As I say, it's important to people's income and finances and hence their socioeconomic status. So also, discussion of occupational factors, it can help you recognize work-related illness. I mean, you can't have an occupational diagnosis without an occupation. So we need to know people's jobs in that case. And we found this when we were teaching for our Echo OEM project, and you can see the logos I've got behind me. And we've been doing that for 3 or 4 years now, again, funded by WSIB for primary care providers. And we found that people didn't really have a useful construct of asking about work and health. And so we put together an occupational history recording tool. And that was developed as part of the Echo OEM project. I'll be going through the questions shortly, so you don't have to read those that are there at the side in the guide to the tool. There's 13 questions there asking different aspects of the occupational history. And the idea is that, as you can see, even in the tool there, that it's addressed about your work and your health and well-being. So it's addressed to patients. And the idea is that patients complete it so that we're not asking physicians or other primary care providers to take their time to be completing questionnaires with the patient. The idea is that the patient brings this into the consultation and the primary care provider can use it to inform the consultation or aspects of the consultation or for their records if they have later reason to refer to it for completing forms or other things. You've then at least got the information available. And it should help then understand the effects of somebody's current or the previous work on their current health and well-being and their ability to do the job. And there's some tools there specifically relating to the ability to do the job. As part of this project, we're looking to make what exists at the moment as a PDF that's printable or form fillable. We're looking to make that into an online tool that we would administer to patients with them in clinics. And as part of that online tool, where we gather the patient's job title, we're going to be using a tool that I developed with my computer science colleague, Dr. Chris Baker, called AutoNock. It's an algorithm. It's a form of AI, but it's what's called narrow AI. In other words, the only thing it does is code a text job title to the Canadian National Occupational Classification. though that's important to do for analysis, because you can't say anything about job titles if you can't, count. If you can't count the number of people that are getting ill through certain causes, etc. What's more, we can link it with the, as I said, you need certain cognitive skills and education. So that's described in, one thing is the Canadian Career Handbook, another thing is an American tool called ONET, and together they describe 83 different functions that you do in a job. And we can pull those together once we've coded the job title. And then we can summarize that and provide that to a primary care provider, so that you don't only know that somebody's a laser beam welder, but a few of the types of things that may be involved in doing that, which might involve getting in awkward postures, for instance. And it may involve certain strength requirements or certain cognitive requirements, and you can then consider somebody as they present to you and their abilities, what you think they would be. So those occupational descriptors can be useful that way. So to talk a little bit more about the occupational history recording tool, these are the questions that are on it. I won't go through it in a lot of detail, but we start off by asking somebody about their employment status. So, are you working or not at present? Because we need to know whether people are in work or not. And also that leads into the next question, which is around whether somebody's currently employed. If they're not currently employed, when did they last work? And, that's telling you, if they're not working, how long they've been out of work. And as I said, there's corollaries that come with that being out of work isn't good for you. And that may have physical and mental health effects on people. Plus, they may be in financial hardship consequently as a result. If they're working, how long they've been in their current job. So, the kind of how well established they are at work, the social network they may have through work. Also, if they've got any work exposures, then if you know how long they've been in that particular job, that also tells you something about how long they may have had those particular work exposures for. And then the important one, what was your occupation or job title? So as I say, the job title is an important piece of information, because it tells us quite a lot about what somebody would be doing at work. But it's not only the job title that tells us that. We can get more information if we ask somebody, what do you actually do at work? What were your main tasks or duties in the job? Because what somebody does, even in apparently the same job title, may differ from the next person. So it's useful to ask that. And as I say, we're asking the patients to tell you, rather than you as a clinician having to ask this information. And then we also ask, do you work in more than one job at the same time? Because it's quite common these days that people have more than one job. And that may indicate some degree of precarious work. For instance, a gig economy, people may be doing sideline work, and some of this work can put people under various pressures. The way people are employed by some of these gig work, they are often made self-employed, which may mean that they don't have healthcare insurance, that they don't have annual leave, they may not have regular work hours. They may, in fact, somebody I came across recently, only doing night work, no health insurance, and having to work 7 days a week, and has been doing for the last 4 years. And, obviously that can affect your health if you're doing that sort of thing, particularly if you may be doing it alongside some other job. And then the working schedule. So does somebody do shift work? Shift work's important as well, particularly if you're working night work, it's going to disrupt the sleep patterns. Plus, if you've got somebody who's doing shift work, then you need to consider what's the impact on health conditions. If you've given them prescribed medication, what should they do when they switch to night shift work? Should they take the medication at the same time or at the same time before going to sleep? These things may need consideration, because it may affect if somebody has a seizure condition, diabetes, etc., these things may be relevant. And with cardiometabolic health as well, we know that shift work predisposes to adverse cardiometabolic effects. There's increased risk of heart attack, increased risk of stroke, increased risk of diabetes, quite a few things. But we live in a 24/7 society now, so we increasingly see these effects. And then we asked people themselves, are there any hazardous exposures that you're worried about in your current job or for your previous jobs? Because, they may know what they're exposed to and they may have concerns. They may be rightly concerned about these exposures, or they may hold, unnecessary concerns, and perhaps they can be allayed if that's the case. Asking somebody if they use personal protective equipment at work is useful. What they're using and why they're using it. Do they understand why they're using it as well? Personal protective equipment, it's often the first thing people think of if somebody's exposed to fumes. Have you got a mask or whatever? It's actually, by and large, least important. Ideally, we'd do other things to remove the exposures in the first place. So if somebody has to use personal protective equipment, it tells you that all the exposures aren't fully controlled, and it's reliant on somebody using the personal protective equipment properly. So there is the possibility of exposure for people. Also, sometimes the personal protective equipment itself can cause problems. Things like wearing gloves when you're, sweating under gloves, that itself, can lead to irritant dermatitis. And sometimes the gloves themselves can cause sensitization and contact sensitizer dermatitis. Then questions around whether somebody thinks they've had a medical condition made worse, caused or made worse by work. And if so, what was it? What do you think the cause was? And again, exploring somebody's concerns around this using the traditional 5 feelings, ideas, functions, and expectations context to explore that is helpful. Whether they know if anybody else has had any problems and what they were, again, it may clue you into if it's a problem workplace. And then there's this question, your current workability, how well you can do your job compared to your highest workability ever. And it's scored on a 1 to 10 scale. And sorry, the 0 to 10 scale. And it comes from the Finnish Workability Index. And it's been at the core of a lot of intervention in Finland over the last 20 years or more, developed by Ilmarinen. And you can use this one question. It's the strongest predictive question of the Finnish Workability Index. As a guide, it's scored, as I say, on a 0 to 10 scale. And if somebody's scoring 0 to 5, it's regarded as poor workability. Moderate is 67, and good is 8 to good or excellent is 8 to 10. And so you can use it in various ways. If somebody's scoring low, you can ask them what it would take to move them to some higher value. If they're scoring 5, what would it take to make it an 8? What would have to change at work? Or what would you have to do differently? So you can use it in the same way you might use a motivational interviewing tool. Or when you see them at a later date, you can repeat it and see if it's changed at all with any modifications that there may have been to somebody's work. And satisfaction at work, are people satisfied with their job? If somebody's not satisfied, that may be giving you some insight into the sort of psychosocial factors that may be going on at work. There may be difficult relationships perhaps with management or co-workers, and that may lead to information around that. So these are the questions that information would be provided through the patient completing these as part of this project, and the tools also available. And what we're trying to achieve in the project is, these are the objectives here, is demonstrating the feasibility of automatically capturing and coding the patient's occupation, using this occupational history recording tool, and the utility of the occupational information that's gathered in the tool, both for the patient and the provider. And I'll explain how we will be looking at that. And if this proves feasible, then that will provide an online tool that WSIB can offer to patients and providers to help capture that information. And since we're capturing it electronically, then it provides the possibility of creating a source of information on worker health in Ontario. So what we're looking to do is to recruit 15 clinics across Ontario. We'd like to have some rural clinics as well as some urban clinics. And the people that we're looking to recruit are either physicians, physiotherapists, registered nurses such as nurse practitioners, and chiropractors, because these are the people that can complete a Form 8. So from a WSIB perspective, this would be a target audience. The clinics themselves that would take part would be provided with 1 hour of training, virtual training on the pilot, on the objectives, and on having conversations around these areas that we've just covered on the occupational history recording tool and how they may be useful. We would send a research assistant to recruit patients in the waiting room. So we wouldn't be asking the clinics to do anything other than give us access to the waiting room to allow us to talk to patients. And as I say, we've been through the research ethics board with our questionnaires and consent forms for the study. And we're targeting to recruit 1,000 patients in total across all the clinics. And then we would follow up with the patients. It's optional, and we would ask them to complete a post occupational history recording tool satisfaction survey, how easy they found the tool to complete, etc., and the usefulness of it. And we would follow up with that afterwards with telephone interviews also. Benefits to participants, both patients and clinics, are the participating clinics would get an honorarium for participating. It's set at $1,000. Any patient who participates would be eligible to be entered for a draw for a gift card. And anyone who participates in the evaluation survey, the participants, or the telephone interview, they would get an additional entry to the draw. And the clinics, we're providing the training to the primary care providers and any resources needed to help support their patients regarding work and health. So that would help them, provide better care related to discussions around work and health. The participants also would have the opportunity to discuss work and health with their primary care physician. It would prompt them to consider those things and to record them before the consultation. And that would ensure any work-related conditions or risks, they can be considered during the consultation. So what does the timeline look like? Well, we're here at the moment, and this is where we're starting. We've already had a period of going through the REB, etc. And we're into this phase of recruitment, and then we'd be looking to recruit patients themselves in the clinics before getting into evaluation through the interviews that I talked about, and then later on going through the analysis of our data and producing some output from this, as well as knowledge dissemination more widely, perhaps through some more liaison with OCAW and other key stakeholders. So primary care providers, what we'd be asking them to do: attend a virtual training session to allow the research team to schedule dates for the research assistant to visit the clinic to recruit patients, engage in work and health conversations using the completed occupational history recording tools during the pilot period, and participate in a post-pilot evaluation interview, a 30-minute interview, virtual interview, to tell us as a provider how useful or what difficulties, barriers there were to using the information as a provider. And Now I'm happy to answer any questions. These are our contact details. The study email is this one at the bottom here, workhealthprimarycare@dal.ca. And I'm open to questions, so I can probably switch off sharing if I can work out how to do that.
Dr. Anesh, we do have a question in the chat from Michelle asking, will walk-in clinics be able to participate?
Yes, if they're primary care providers, then don't see that as being a barrier because they'd still be able to complete the Form 8, and that's really our criteria for saying, would somebody be able to participate or not?
If we have any more questions, please feel free to raise your hand and unmute yourself, or you can place them in the chat as well.
And if anybody doesn't feel comfortable asking a question in the group, as I say, feel free to email us, and we'd love to hear from you because we're looking for participants. I think, has Michelle raised their hand? Is that right?
Michelle, is your hand raised or?
Yeah, I can see a raised hand. Michelle, do you want to open your mic? We're not hearing you if you're speaking, Michelle. So somebody's asked, I think in the chat, I saw something, a question there about where would the clinics be located? I think that's what it was. Let me just see, can I see that?
Yes, that was the question.
Okay, so Ontario, essentially. The study's taking place in Ontario. So if you're in Ontario or if your clinic's in Ontario, then that's fine.
So yeah, we're really hoping to
Anything in Northern Ontario.
yeah.
If you're in Northern Ontario, that's great. So
Yes,
we'd
we
be
want
happy
some
to have
remote,
something.
rural. Yeah. Trying to recruit. We're trying to recruit. That's what this session is all about, really. Michelle, I'm not sure. I'm trying to help you if Kate, can we help unmute Michelle, or does she have to push the button herself? I requested her unmute, but I don't know.
I don't know if it's got anything to do with this unverified bit, but will that maybe stop her
I
unmute?
also just requested.
Tried that? Okay, I tried that. Okay. Wonderful.
Yeah, if we don't get to hear from you, Michelle, please do drop us an email and we'll get in contact and answer your question that way.
If anyone did not see, I did put Dr. Anil Adishesh's email in there, as well as Caitlin Ford and general study inquiries as well.
And thank you, Robert, for your comments there.
Thank you. Wonderful. Well, if there are no other questions, and we can't get, I'm going to request Michelle again. Michelle, there's just a little microphone in the top window or at your screen, the mute that you just unclick, but you might have just said thank you or something and you don't want to unmute. Oh, I can't unmute.
Michelle has posted her question. So she's having difficulty unmuting by the look of it, but she says the question is that whether you're anticipating current health problems versus current health problems or disease which may be work related. And the answer is we don't mind. So all we're asking for is for the patients themselves to complete the occupational history recording tool in the waiting room prior to consultation. And, you know, depending on the type of issue that they happen to be consulting about, it may be a new problem, it may be a chronic problem. or it may be a work-related problem. I mean, on the whole, it's less likely to be work-related because the majority of reasons that people consult primary care providers are not for work-related conditions. And that's why, I'm very keen to see that, people think about work in anybody of working age, because, if you have a patient with a medical condition, let's say it's rheumatoid arthritis, it's not caused by work, but it may affect their ability to work, and that matters. And when you do have somebody then with a work-related condition, the same principles apply. So, except if it's work-related, you should be able to get more support from WSIB, etc., to help get somebody back to work or with their treatment. So in those circumstances, there ought to be more support available. And Janice has posted something. And commenting around asking further information about the nature of the workplace. And this is why, it's a start, Janice, if people will ask the job title. It's not routinely done. And, as I mentioned, asking about the types of activities that somebody's doing, that's additional information, all the better. But then also that's why, with our algorithm, we can provide additional information once we've got a job title to tell the primary care provider the types of things that somebody may be doing. But there's nothing better than asking somebody themselves, and ideally getting a job description, but you don't always have that, and it always takes more time to be getting these things, and time's precious. So does it provide an opportunity to drill down specific exposures? Kevin's asking, with his occupational hygiene hat on, such as lead, benzene, etc. It would do. I mean, as I say, the exposure, there's an exposure question there in the occupational history recording tool, and if somebody mentions that they had exposures to any of those substances, then they could be recorded there. Or if it was a more general comment, the opportunity for somebody to ask is, well, what types of exposures do you know of? Or, and when we give some training, we can tell people about safety data sheets if they're not already aware of them. So yeah, it's all starting to prompt people in the right direction. Michelle has said, I've heard the likelihood of health issues being work-related is in the area of 40%. So this is a great opportunity to identify those. Well, I think it depends on the particular health issue, and and the exposure in question as well. Again, you can't have an occupational disease without an occupational exposure. So Kevin's point's also well made there, that we do need to know about the exposures, but trying to recognize these things is great. Yeah. Yeah, and as Kimberly says, it's an effort to break down barriers to discuss occupation as family physicians. So it's a first step. We can always do more, but it's trying to give some tools that should help move this forward on the agenda for primary care. Yeah.
Great. Any other last questions from any participants about this research? And hopefully you all know primary care practitioners. You have them, you know them in your communities, in remote areas. We would love help recruiting for the project. So please do reach out. That we're hoping that we wanted to get this in just before the summer holidays and then use the recording and spread it widely if we didn't catch many today. So really just want to thank Caitlin and Dr. Adisesh for sharing with everyone today your presentation and your great research and wonderful work we're embarking on together. And thanks for coming and sharing it today at this nice lunch and learn. So everyone's got their recruitment hats on now and can get us some folks for the study.
Yep. So if you're interested, well, maybe you've got some friends that might be too, so do let them know. Thank you very much, and thanks everyone for attending.
Thank you.